Thank you very much, Professor Coates. I hope you can hear and see me well. I apologize for not being there. For not being there with you this year, but I hope next year we can also be there in person. Thank you for this very interesting meeting. I am a hematologist, as you kindly introduced me, but I also have some background in cardiovascular risk, so I think that is a perfect topic for me, and I hope that I can give you an approach that is multidisciplinary and also interesting for all colleagues that deal with patients in cardiovascular risk. Today we're going to focus in hemophilia. And hemophilia, as we know, is a bleeding disorder, and therefore it is very hard to find a balance between the bleeding and thrombotic risk in these patients. But what do we know about the cardiovascular risk, especially as hematologists? We try to understand all the efforts in early prediction of cardiovascular risk. And as the audience very well knows, this is a vicious cycle between endothelial dysfunction, microvascular alteration, and macrovascular alterations. And all these lead to the traditional cardiovascular risk factors that can be more easily assessed in clinical practice. But early prediction, especially in these difficult patient populations, might be important and might give us more food for thought for future risk research in this population. In hemophilia, to say a few words about this changing landscape, we're very grateful because we deal with a rare genetic bleeding disorder, as we already mentioned. Hemophilia A, as we know, is a factor VIII deficiency and is the most common one. Hemophilia B is a factor IX deficiency, less common, but we also have some patients with even more rare bleeding disorders. The incidence is worldwide almost similar, and we mainly deal with male patients, but females are also considered carriers and can have a phenotype compatible with increased risk of bleeding, and this is an area of current research in this field. We actually have an easy way to stratify the risk of our patients by measuring the clotting factor level, and traditionally below 1% is a severe form, and 1 to 5% is a moderate form, and 5 and above is a mild form of hemophilia. But what we currently understand is that the bleeding phenotype may be more important than the actual factor levels. And why did I say that we are very happy in this field? Because we have actually climbed all this ladder that is shown here in this slide. And over the last decades, we were able to move forward from achieving better survival, minimal joint impairment, freedom from spontaneous bleeds, attain a normal mobility for this population, able to sustain minor trauma, to undergo major trauma without additional intervention, and our goal for the future will be to achieve normal hemostasis in these patients. And this is just a very short timeline of the developments in hemophilia A and B, where we have now long-acting factor replacements and also bypassing agents such as emicizumab. And we are also very grateful to have approved gene therapy approaches that are expected to change the future for our patients. And these are already approved, and we know that we can sustain the factor levels for several days at the normal level with the factor replacement, and ideally also bypass these hemostatic problems. But let's focus now in our question. Do we have cardiovascular risk in hemophilia patients? Some years ago, we have tried to summarize current knowledge at that time about cardiovascular risk in hemophilia, and this knowledge has also been updated by more recent studies in the field. We know that thrombin has an essential role in anticoagulation, and hemophilia therapy allows for normal thrombin generation. In addition to the measurement of the factor levels, we now try to understand more about the bleeding and thrombotic risk, the balance through novel assays, and these include the thromboelastogram, or TEG or ROTEM, the thrombin generation assay, and also the analysis of the activated the APTT. So these assays, this is an interesting more recent review trying to summarize the role of these assays and how can we interpret them in patients with hemophilia. For the sake of time, I won't be going into more detail, but we are also trying to integrate these assays into our clinical practice, especially in patients that need surgery or are in increased cardiovascular risk. But we also have a multifactorial phenotype to deal with, and from one side is the thrombin generation related factors with the severity of the disease, but also the PK profile of the proteins, which we are trying to assess in all our patients. Some mutations that may alter the phenotype of our patients, even thrombophilic mutations in patients with hemophilia. And then there are all the other factors, the choice of prophylaxis, the management of acute events, the joints that have already been in pain in these patients, the physical activity levels, the gender, and factors affecting vessel wall fragility. So this is a difficult balance. And thrombosis in hemophilias, does this exist? You can see that there are not so many data in the literature. So this is a small table summarizing data from the European database, showing that indeed thrombosis exists in a significant percentage of the patients, analyzed 3,000 patients, and almost 300 did have a thrombotic event. What do we try to understand as hemophilia experts in these patients, and why do we need an interdisciplinary approach and a very good collaboration with our colleagues that have a better understanding of these diseases? Is that we have to understand the difference between primary and secondary prevention, the necessary management of acute thrombotic events, that sometimes one prevention is not the other, and that sometimes that bleeding risk is also determined by additional factor levels as our patient population ages, anemia, renal function aids, hypertension, and all the other risk factors. And of course, we have to take into account the patient preference to deal with this management. And so this is just a table summarizing small studies in the field, trying to show the factor levels and the different anticoagulation that can be administered to these patients. When can we administer one antiplatelet agent, dual antiplatelet treatment, the new acenocomarol or DOACs, and which threshold of factor levels do we need in these patients. So the single antiplatelet therapy is almost for everyone, as shown in this table, But for the other agents, we need to keep a factor level of 20% or above with our treatment. So for this reason, we need to personalize our treatment, because as we have seen in these previous diagrams, we are trying to keep the threshold above a safe level, but our safe level up to now was almost 5%. Now, in these patients that receive anticoagulation, we need to have a safe level of 20% and above in most of the patients. So we need to have also careful adaptation based on the general population guidelines. And this was the reason that a specific guideline has been generated for people with hemophilia. BWH is the acronym for these patients, and how we deal with them when they present with atrial fibrillation. So we already have factor level of 20 and above, then we consider this patient at high thrombotic risk and we can administer DOAC. If we have a factor level of lower than 20, then we have to consider whether we can increase this factor level based on the individualized risk assessment. Acute coronary syndromes, and this becomes more often in our daily practice as the patient ages. In these patients, we need a trough factor level of 80 and above, so we need to intervene with our therapy and basically proceed like all other patients, and keep these factor levels for at least 4 weeks. With a trough level of 20, and then proceed to single antiplatelet agents. For VTE, the current guidelines do not recommend the use of routine pharmacological thromboprophylaxis in our patients. An individualized approach in surgery, and they recommend against extended duration of pharmacological prophylaxis. So are new hemophilia treatments more protective for our patients? So we do not have a safe answer for this question, but these bypassing agents, as we said, like emicizumab, they are considered to offer a relatively stable factor level of approximately 10%. And so, therefore, they're considered to be acceptable for single antiplatelet agent, but we do not have enough data for dual antiplatelet treatment. And so the current guidelines do not suggest to switch from other prophylaxis to emicizumab only for this purpose. And to summarize our experience from our hemophilic patients in the center of northern Greece, we currently follow up 54 hemophilic patients, and we have recorded acute coronary events in 3 individuals. We had a successful outcome in all of them with prophylactic treatment and dual antiplatelet treatment as indicated, as described in the current guidelines, but we need to highlight the personalized approach and even the very good discussion between the team dealing with the thrombotic risk and our team in these patients. So the take-home message, I think personalized treatment is needed in these patients with good interdisciplinary work. We might be able to perform future studies for early prediction of cardiovascular risk, and even highlight the patient population that are in decreased risks. And with new treatments that we are expecting, we also expect new challenges in our field. So thank you very much for your attention, and I hope we have time for discussion.